Good evening, our friends and stakeholders. You're welcome to this webinar, um, this platform. And we also need to have our speaker, Mrs. Bamyil A. Will introduce it. I will try to make it as possible. So Mrs. Saleh is a psychologist with MSc, and she is an IVF administrator and a counselor. She's the current treasurer of our association. She's a member of the International Council of Psychologists. She is a member of the American Psychological Association. She's also a member of the British Infertility Counseling Association, a member of the Nigerian Psychologists Association, and also a member of the Nigerian Association of Clinical Psychologists. I want to believe that we are going to have a wonderful session listening to her today. And I will want to hand over to Mrs. Bamyil Saleh to make her presentation. Thank you so much for having me once again. So Mrs. Saleh, over to you. We are all listening. Thank you.
Thank you very much, Professor Makwe. Good evening, everyone, and welcome to another series in our another presentation in our counseling series. My presentation topic is fertility and family planning, addressing social and emotional aspects. And this is the outline I'll be discussing today. And we have just 1 hour, so I'll try and do justice to the topic and accommodate the questions and answers. Now, as a form of introduction, we all know how emotional infertility, fertility treatments and the outcome are. And we know that usually the family are also affected, and the society, they are also involved in the couple's fertility journey. So we know that many individuals and couples that find themselves facing infertility are usually disappointed because of the unmet expectations at the end of the journey. And this usually generates some complex emotions on them. That's on the part of the treatment. And then when you add the expectations of the society and the pressures that come from it, then it makes the journey even more tasking on this couple. So I will try as a form of objective to discuss or illuminate those specific social and emotional dimensions surrounding infertility and its treatment, and then the family planning, while providing practical guidance as per how to navigate these intricate experiences. The emotional aspects of infertility are well documented. I don't want to repeat what we already know, but as a form of mention, we know that patients who go through these treatments experience emotions like anxiety and stress. They go through periods of grief and loss, and for quite a number of women, self-esteem and identity is also affected. Now, coping with emotional impact, 2 series ago, we discussed the emotional responses to fertility and fertility treatments. And so I'll just mention, just to refresh our memories, we know that the impact of when the challenges are quite enormous on this couple. And so what they should do, or what they do to be able to alleviate that on them, is to seek support. They consider counseling, which is key. They practice self-care, and then reframe expectations, especially negative expectations on them. So how do they navigate these relationships and social pressures? We know that these couples usually, like already mentioned, There are traditional expectations, family building expectations that the society or the community has on these couples. And if they feel they cannot meet up, they usually express it in forms of guilt, shame, anxiety, like mentioned, and it is overwhelming. It can be overwhelming on these people, and so they have feelings of isolation and loneliness. So they feel detached from society or from those expectations that are uh, pressurizing them. And what do they do? Like I said initially, communicate openly. You know, it's one thing to be dealing with emotional issues, and it's another to speak about them. We know that it is said that a problem shared is half solved. So when they openly communicate, or if we encourage them to speak openly about the pressures, then it will help them. We also help them to set realistic boundaries, because people live in societies and they tilt towards doing what, or feeling like they are pressured to do what society expects, not regarding themselves as per what can I accommodate, realistic boundaries to be able to maneuver effectively. Okay, so seek supportive communities. People have found solace in support groups, people dealing with similar issues, or people that have the patience or the ear to listen, and listen on objectively or without judgment. And then you encourage them to practice assertive communication, positive thinking, and positive speaking. Now, I also wanted to bring out sources of where these pressures usually come from. And we know that as Africans, as Nigerians, we are community people. And so some of the sources where these pressures come from are from family and friends. Is it the nosy aunt who will not mind her business? Or is it the advice giving friend who would want to help you in their own way? Or the disapproving mother in law? Another source could be the community or cultural norms. Now, these expectations for large families usually gives these couples some kind of infertility stigma, and so they tend to stay away from family gatherings and situations where they will face this kind of expectations, or they will verbalize it to them. Okay, so we have also expectations on early marriage and childbearing. They tend to tell you when it is safe, or when they are expecting to see children coming from you. We also have social media pressures, where people post their lives on social media. That's another form of peer pressure, and they give you this idea of perfect family, you know, and so you are at pressure to also share. So what if you do not have a family? Then it looks like you are a different person, or there's a pressure on you to feel shame, or feel some kind of displacement in that group. Okay, or the comparison game. This person is this placed here, this is the number of family, or these are their achievements. Those are the kind of pressures that are witnessed on the social media. We also have religious and spiritual beliefs that are basically shared within people of common religion. So we have the major religions in Nigeria, Islam and Christianity, and even in that we have different sects. And then the expectations about fruitfulness, what the holy books say about it. We have the stigma of infertility, especially in faith communities. They make you feel like your faith is not strong enough, or you are not practicing the faith the way it should, hence your challenge. Okay, and then the pressure to always pray at gatherings or meetings, pray for children. And so these are the sources where pressures come from. Now I'm going to delve specifically on the kind of pressures that come from those sources. So from the family and related pressures, you hear about parental expectations on their children to get married and have children within time frames, which I already mentioned. Family gatherings can be very stressful for individuals and couples who are struggling with infertility and childlessness. Now, this is because some of them try to avoid situations where there are children or even married women, but at family gatherings, everybody is there and everybody is, even if they are not verbalizing questions, they are looking at them in some sort of way. Okay. And then sibling comparisons, which parents usually do, whether deliberately or indeliberately or not deliberately, so those keeps pressure that is on the couple based on the family. Then there are cultural and societal pressures, cultural norms. That seems to be the normal thing that happens in certain cultures, like keeping the lineage alive and for heritage purposes, social stigma from couples who are unable to have children. It makes them to feel embarrassed most times. And then community members, they expect them to build their families in the traditional way. So there are still cultures that do not accept even ART that we present to them as a way of building families. Next slide, please. Then we have the, let me be for me. Next slide, sir, please.
It's not moving?
No, it's not. Maybe I'll just, and the technical issues today is a serious one.
It's not
Maybe
moving
I'll
here.
just, no, I can't see it. So I'll just open it on my own system and then keep talking, and then they will share the slides later, I believe.
Okay.
All right?
All right.
Hello, sir, Mr. Chair. I think she should just continue the presentation and the slides can be shared later.
Okay.
Yeah. All right. So then we have the religious pressures that usually some religions, like I mentioned, emphasize the importance of having children as a way of fulfilling divine purposes. So you have been, you have been created to fulfill, to multiply and fill the earth, things like that. And then the congregational expectations, where individuals are expected to conform to family building expectations in religious wise. Then the media and social media pressures, usually comparisons like initially mentioned, and then false portrayals from what the social media sees as ideal. Then we have other pressures that come from the workplace and the economy. There are certain policies at workplaces where you are expected or assumed that you will have children, and so there are benefits that are attached to having children or to children, and that can be another source of pressure to the couple. So what are the ways in which couples can help to curb these pressures? As it is evidently psychological counseling, which is a structured relationship between you and a mental health specialist to be able to help them cope with these pressures and be able to live fulfilling lives even without children or without the traditional way of family building. Then we have the mind-body interventions, where cognitive behavior therapy is key, where you do certain things like yoga or mindfulness or exercises to be able to help you have a mental balance, joining of support groups for people dealing with the same issues or people that have been able to surmount their challenges and hear their stories to build your strength. We have where they are advised to develop good mindset to be able to live a fulfilled life, for them to also cultivate self-compassion. So self-care is very evident here, so that they take care of themselves and not allow what happens outside the self to depress them or make them feel less than who they are. So also build support network within the family and friends, even though some of them are sources of pressure, but they can identify people that can connect with them or people that can help them to strengthen them through the journey. Also to engage in activities that promote joy and fulfillment. That's another way. So I have put here other family planning treatments apart from the conventional ones which we know, like IVF, IUI, gestational surrogacy. We have processes like adoption, which is recognized globally. I also know that in Nigeria, a study was carried, and about 71.4% of those who adopted children reported satisfaction with their experiences. I know that couples come in and they are wondering, if I adopt a child, it's not the same thing as having my own child. So you counsel them, especially those who are their age limit is above our statutory age for IVF, which is 54, or those who cannot have IVF using their own gametes, or those who don't have the finances to do IVF cycles. So such people can go for adoption, even though I know the process is not easy, but that's one way of family building. Another one is foster care, which is also common, where families take in and live with a child or children until other options are available for them. So they have the opportunity to take care of children under them. We have another method, donor conception, especially for those who cannot use their gametes. This is a bit controversial in some religions and also some cultures, but we have the donor egg program, which is supported by some religions, some aspects of Christianity and Islam. We also have the donor sperm option, where if there are issues with the male gamete, that option can be discussed with the couple and for them to be able to accept consent and go ahead. That too is controversial in some religions and some cultures. And some of the controversies in these forms of family building are, for instance, cultural stigma, where the family feels that child is not genetically related to the man and so might not be an heir in the family. We have also religious concerns, where some feel that outside the natural way of procreation, that will be playing God. Then we have issues of regulations, where practitioners who are focused on maybe profit do not go by the regulations, where we have so many funny stories of mixing of gametes or doing things that patients do not consent to. Yes, and then we have issues of anonymity and confidentiality. I know this is key to patients, especially those who come from outside the country. They want to know, to what extent do you screen the donors? How much information do you have? What what level of confidentiality do we have? Will the donor be able to identify that we are the ones collecting the gamete? Is our name being published anywhere that it is not, where we don't feel safe? So these are some of the controversies and concerns that are expressed when building family through this method. We also have issues of commercialization of sperm donation, and even though silent, but it's happening in places where they are not regulated. And also issues of inadequate counseling and support. So it's a different counseling when you're doing for patients that are building their families through IVF with normal parameters, and a different form of counseling for those who need to use donor gametes, so that they know that the child should be prepare them to accept the child and bond with the child and take it as their own. Then we have donor embryos. Recently, we had two sisters coming, one under 30 and the other one above 50. And the one under 30 came to the clinic to freeze her own eggs. That was the first primary reason for coming. But then the sister who accompanied her wanted her to also donate eggs for her. So it's something like egg sharing, if you like. So that is a possibility where they want to keep the DNA within the family. So sisters can donate to sisters, as well as brothers can donate sperms to brothers. Those are other forms of family building. So I'm coming to the end of my presentation, unfortunately, but I've identified some ways forward that will help us as clinicians and also help the public. And I think that we still need to do a lot of awareness and education about the different forms of family building so that people will accept it, so that when there's more information or awareness in the society, in the community, there will be less stigmatization on those who have to do it, and then there will be more of support so that people can take decisions knowing that they are safe with those decisions. And then cultural sensitivity is very key, especially for practitioners, because we see people from all sorts of culture, Nigerian culture, Western cultures. So we need to be sensitive to be able to address couples, to navigate the emotional complexities around infertility and family building. And then the issue of policy and legislation. I know that AFRH is doing a lot about regulation, and that needs to be adopted and personalized in every clinic so that we're doing the right things right. We're offering the assistance that we're doing in the regulated, legalized manner, where issues will not arise following the birth of the children or when years pass and there's a need for people to follow up and find out information, so that those details that they need to have that are legalized, everything is done in the proper way. I have come to the end of my slides, but I will not stop by letting us know that infertility, this is not news. Infertility, its treatments and family planning are complex and deeply personal experiences, right? And so they can have profound social and emotional dimensions which patients or our couples. And the Nigerian culture, the social religious norms are significantly impacting, or they are a drive to each couple's experience for fertility and fertility treatments. With this said, I want to thank you for the opportunity to make this presentation. I hope that I've been able to help us understand and stimulate questions, not for me alone, but also for each one of us to think through and help our patients to be able to build their families in a safe environment, from the clinic up to the society. Thank you.
Thank you so much, Mrs. Sally, for that wonderful presentation. I want to apologize on behalf of the association on the technical hitches. Sometimes when you deploy technology, I always tell people expect the unexpected, even when you have troubleshoots the technology and you think everything is perfect. So thank you very much for that presentation. I want to hand over to my co-moderator, Mrs. Lana, for any comments before we put the audience, open the floor to the audience for question and answer section. You want to?
Okay, thank you very much, Bamyil, for that wonderful presentation. We have been enjoying your series of presentation, and I want to thank you. especially for this presentation. And I would like to ask the audience that if they have any questions, they can go into the comment sections and drop their questions. Thank you.
And for the back end, the secretariat, I hope we will be able to see all the comments or questions from participants.
Yes, sir.
Okay. So once more, this is Sunday. We thank you, and we are open to your questions and sometimes comments and any additions to the topic. Thank you.
Okay, before I don't know if there is any questions. There's no questions from the chat box. But in case anybody has anything to say, maybe you have some, Dr. Christian, maybe you have something to add. Pending,
Yeah, so,
okay, there's a hand up.
Yes, Mrs.
There's a
Adewusi,
hand up.
please. You have the floor. Thank you.
Mrs.
Hello.
Abiola Adewusi.
Hello,
The floor is yours.
good afternoon, everyone. And Bamyil, thank you very much for the presentation that keeps opening our eyes to the very important aspect of ART or any kind of assisted conception. Most of the time, when patients come through to the clinic, we just take them and say, okay, this is what you wanted, baby. We start the treatment and we go. We often overlook the emotional baggage that comes with the treatment that they desire. And sometimes, depending on how we handle their emotional side of things, it may actually be better handled when it's a negative outcome as opposed to the expected positive outcome, because we all know that ART treatment or assisted conception is not 100%. So 70% of the time, or 60% of the time, or 50% of the time, it comes back the way we don't want it. And that's when it dawns on the practitioner themselves that, wow, okay, so how do I handle this? And so, given a negative outcome, consultation becomes very difficult just because we haven't done the background work on supporting them emotionally and managing their expectations. So I think this is a discussion that we need to keep talking about so that we don't lose focus on the emotional end of things. Thank you very much.
Thank you so much. Thank you so much, Mr. Adewusi VP. I think we have questions now in the Q&A box. I will read the first one from Barrister Odinga. Our question goes, how do you manage situations where the patients insist on unethical choices, especially regarding deception about gamete donation? Mrs. Sabe, I hope you got the question out. Do you want me to go over it again?
Yes, I got it, sir. So couples that insist on unethical practices, especially about gamete deception. Now, I'm assuming, is it we're using donor eggs and the husband does not know or wife does not know? That's kind of unethical, right? Or you're using gametes and the couple are not aware of. Now, anything unethical, it will land us in the law courts. But if couples insist, I think we'll be safer with sticking to the truth transparency, sticking to the truth, and ethical practices. I know that that's the safest thing to do. So counseling and bringing them up to page, to understanding, so that they can take a decision rather than tilt towards unethical practices. For me, I think that is key. It's easy to say, I'm sorry, we may not be able to continue with your treatment because of A, B, C, than to go forward, do it, and then in another 2, 3, 4 years, when they come back, you cannot even, you will not be able to be free when the law catches up with you. I think that would be my answer, but the panelists or anyone is welcome to add to it.
Yeah, thank you so much, Mrs. Sally. I strongly agree with you. There is no room for unethical practices when it comes to medically assisted reproductive technology. So one of the things that we have to do is to adequately counsel our patients and also make it clear to them there is no room for unethical practices. All right? We understand how difficult and challenging it is when it comes to gamete donation. In some other plans, what you do for you to have gamete donation, you go through a series of counseling. Some of them put a minimum of 3 or 4 sessions to make sure the couple understand what they're going through. Okay, and where the couples involved have reservation, there's nothing wrong as practitioners to say we cannot do this because it's unethical. There's need for full disclosure, because the way the world is going so global, we have had issue where such disclosure were not made, and people want to migrate to Canada or US, and the children DNA were requested, and things that you thought were hidden became revealed, that one of the spouses is not the genetic parent of the babies. And when the other partner does not know, you can understand and believe that that is a big challenge for the family. And sometimes the family breaks down, and there are a lot of legal issues that come in, and that can be very sad for the fertility clinic that are involved. So I think full disclosure is always important. Those 1 or 2 clients that we want unethical, if we do by the books and decline, they won't find where they will do unethical practices. And I think that's where we should go. I know my chief, Dr. Kiola, has more to add, because I believe that all of us would have encountered such kind of couple of clients. Dr. Kiola, over to you, sir. Thank you.
Thank you. I want to ask Mrs. Saleh, thank you for the brilliant lectures you've given us to now, and they are at the core of fertility treatment. There is no fertility physician or consultant or specialist that will take on board, a good one that will take on board a infertility couple for treatment without proper counseling. So this is very, very crucial. These topics we are dealing with now is very, very crucial. It's at the core of fertility treatment. Now, I want to ask you a question. Now, you have a couple that are undergoing fertility treatment. The wife's egg reserve is very low, and the couple insisted on her trying our own, using our own eggs. However, you are not having any headway getting good embryos from the woman. You get, maybe at the time you get 1 or 2, by the time they reach day 5, nothing to transfer. And then you now give them the options, madam, you have tried once, twice, or more without getting any headway. Now it's time to consider egg donation. The wife agrees, but the husband disagrees. So how do you, as a counselor or experienced counselor, how do you navigate this situation where you bring them sit them down, explain the situation, and try to convince the husband, because the husband is adamant that I don't want any external gametes. So how do you tackle that kind of situation? That's number one. Then number two, regarding family planning as well, it used to be that a woman can hardly make a choice about family planning without the husband's consent. I remember when I was training in UK, if any woman comes around to seek contraception, we always bring in the husband that, look, have you discussed this with your husband? Has he agreed? Is this still the practice, or because of the situation of things now, human rights and everything, it has changed? How will you also sit a couple down, convince the husband that refuse conventional contraception to agree that, look, man, you have 6 children. I think this is time. Or your wife wants to have sterilization, but the husband disagrees. How do you tackle such scenarios where the husband disagrees both ways for egg donation and for contraception for the wife?
Oh, before you answer that question, Dr. Christian, can you take the other second question on the chat
Yes,
box, please?
okay. Let
So
me
that
just
you
drop.
join and answer them.
Let me drop the second question from Akomo Eniola. The question goes: a lot of couples are scared of surrogate or surrogacy. Like, what will people say when it comes to them having a baby through surrogacy? How do we advise such couples or convince them? So I think the question is trying to highlight the fact in this environment, couples who surrogacy might be ideal for them as an option are always concerned and worried about what people will say. Probably they didn't see them pregnant and suddenly they have a child, which probably they got through IVF surrogacy. Okay, how do you counsel or advise those couples against those social stigma and influences that comes with surrogacy? I think that's what Enela is trying to find out. So you can take that with that of Dr. Akiola together. Thank you.
Okay, thank you very much, sir, for the questions. Now, you know, in IVF, as a counselor, you don't advise your clients, you don't decide for them. The best you can do, honestly, is to counsel, give all the information that there is, and let them decide. I will tell you what my boss will say: you cannot coerce a couple or a spouse into deciding what in their mind they have rejected, or in their hearts they have rejected. So you cannot coerce, but one thing you do is give information. For the first question that Professor Akinola asked, you want to find out from the man what his reasons are for rejecting the option that the wife has accepted, maybe on a separate counseling, so individual counseling now, and try to find out. It's possible he may have children of his own that the wife is not aware of. It's possible the dynamics of using donor eggs, he's not able to wrap his head around it. Then you open it up and give him all the information, and then you help them with other forms, other sources of having children, like the adoption, like the foster care, and things like that. I know that recently we had a man, the same scenario you've painted, sir, that the woman came to us and said there is no form of counseling that they have not attended. The man knows everything, he has heard everything, he speaks like a counselor, but he's refusing to accept for her to use donor eggs. There was family intervention, so you take advantage of their social support to be able to see if you can break through. So for this man, he's a single child, so there's no pressure from any sibling. So you may also want to go through the sibling, that's through the wife, advise her to speak to his relatives. Maybe they'll be able to lord over him, because there's this family, usually when the family meets, there are decisions that they can take that can also support in that. So give them options, find out information from him, and then guide them for the decision. In our culture, the man is the king, and so the wife hardly, I know that some talk about rights and all, but these are people whose cultural values have been mixed with the Western acculturation, But the man takes the decision, is to speak with him as an individual, and also um, support the woman to be able to accept other options. If, because he can decide not to bring his sperm samples, then what way forward do you have? Nothing at all. So that would be my counsel for that particular scenario. And then I think it's the same for all three. You cannot coerce anyone into taking the decision, even if you see it as the best decision for them. With information and guidance, maybe you give time, and then follow up will help to check if they've changed their minds. I don't know if I've answered that question, Dr. Professor Akinola.
You
Okay.
Thank you.
treated it very well. You treated it very, and I completely agree with you. We can't force, you can take a horse to the river. You can't force the horse to drink. So we cannot coerce them, as you said. We have to counsel them and see and try to bring them to reason how they can adopt,
Other options.
other options. And
Yes.
if they refuse, well, we just have to pray and then see them, maybe
And follow them
periodically
up.
that they change. Yes, we have to
Yeah.
follow them up. This
Yeah.
this is becoming very common, where we are, especially when religion also comes in, or there is a family pressure that comes in as well. And on the third question that was asked, but that was read out by Professor Makwe, now it's saying they are using surrogates. Now the surrogate was living in a house, and then suddenly they saw her pregnant. Then there is no baby, and when she comes back, so people will ask. And we have couples, like that, the genetic parent will say, okay, my wife will go and put something in the tummy and make it look like she's pregnant. Or the surrogate will leave before the pregnancy comes on, becomes prominent, and move to another house. And then when she delivers, she can come back. But even sometimes this time, they don't even move house. And then you say, my neighbor, what's your concern? Are you the one that put the belly in my tummy? Or sometimes the husband also knows about it. So the husband and the wife, they know. So it's going to be difficult for the wife to leave the matrimonial home and say, okay, because I'm pregnant. So it's a very, very complex issue that we need to be very careful when we are dealing with this. And I'm glad we have support agencies now that are dealing with such issues. Maybe for us physicians, we are not very, familiar or conversant with the all aspects of the counseling. We just push it to the support agents. Okay, you handle it. Let me handle the clinical aspect. Thank you very much, Mrs. Saleh. This is a very, very important a topic that we just have to, we don't have any choice. We have to know how to counsel our patients. Thanks a lot.
Thank you, sir. And may I add, this topic about surrogacy is a very sensitive one. And I will tell you what, we have seen both scenarios play out. We've seen a surrogate whom, before she left where she was staying, because we usually house, she told everybody in her area this is the program that she was going for. And so with personal disclosure, there's nobody looking at you in some sort of way. And she told them she was coming to XYZ hospital. She did her program. She's done. She's back to her community and nobody is looking at her in some sort of way. So I think the acceptability of the program is key. So more awareness and for people to know that there are options. We don't do surrogacy for aesthetic purposes, do we? It has to be medical, right? I think that's what we try to practice. There has to be a medical reason to say my wife cannot carry for this XYZ reason, and so this is the option. So it's an option for family building. So it depends really. Sometimes what the couples do is self-stigmatize. And so when that is handled, then it's not anybody's problem anymore. I think they can walk with their heads up high, even having done created their family through surrogacy. It's gaining more awareness now, and I know that 5, 8, 10 years ago, we used to do it in hiding. Let people not see you, but now nobody cares. We have a patient who came from Cameroon, and I tell you what, hers was successful. We have her whole family members, or let me say people from their their family, because they share the same surname, asking questions and wanting to refer their friends. So if we keep it secret, then that's where the problem is. I think we should talk more about it. Let people know that it is all right to build your family if that is the option that you have through surrogacy. Thank you, sir.
Thank you so much, Mrs. Saleh, for all those insightful comments and explanations. So I will hand over to my co-moderator, Mrs. Ilana. Do you have any word before, because we have addressed all the questions from the Q&A. So before we close, any comment for the audience and the participants?
Okay, no comment. I think she did a beautiful presentation. She's an expert in counseling, and we have learned a lot from her too. Especially counsel our patients very well. It's very important. Thank you, Bamyil, for that wonderful presentation.
Thank you, Mrs. Bamyil. Thank you so much. We cannot thank you enough. We know it takes so much time to prepare and come to deliver, and we appreciate you for all you do for the association. Before we go, I want to remind our audience, our colleagues, friends, and stakeholders that we should remember to follow up on our social media handles, AFRH Nigeria. We have different platforms. We have the Facebook, LinkedIn, Instagram, even the X, So I encourage all of you to follow us and like our content as much as possible. Where you have any advice, comments, or things that will improve our social media platform, please do not fail to reach out to us and the secretary. But we would greatly appreciate if you can follow us on our social media platform. Thank you so much. I want to call on the secretary. Is there any information that is needed or relevant for our audience before we call it a day? Okay, in the absence of any other comments, I want to say thank you. We are just on time, so we keep it at 1 hour. So thank you and God bless us all. Bye-bye.
Bye-bye.
Bye.
Bye-bye, everyone.
Bye, everyone. Thanks for coming.
Thank you.
Thank you, Mrs. Saleh. Nice presentation.
Thank you, Prof. Thank you, sir.
Our very own Bamyil.